Good afternoon. I am Luca Arecco. I'm a medical oncology resident from the University of Genova and San Martino Polyclinic Hospital in Genova, Italy. And today I would like to discuss the results of our analysis that we'll be presenting at ESMO 2024. And the title of our abstract is The Prognosis of Patients with Hormone Receptor-Positive, HER2-Negative Early Breast Cancer According to monarchE and NATALEE Trial Risk Categories. This is a patient-level analysis of Mammella Intergruppo and Gruppo Italiano Mammella randomized trials. Just a little bit of background, because as we know, there are two trials that now prove to have improved the efficacy of the adjuvant endocrine therapy in the early setting, in the adjuvant setting of the hormone receptor-positive HER2-negative breast cancer. And these are the monarchE and NATALEE trials that, with different length of follow-up, they both demonstrated an improvement in the primary outcome, which is the invasive disease-free survival. However, as we know from the design of the trials, monarchE and NATALEE trials apply different inclusion criteria to define the patient at high risk of recurrence, which can be considered eligible for the inclusion in the trials and therefore receive the CDK4/6 inhibitor in the adjuvant setting. The monarchE trial included only patients with node-positive disease, while the NATALEE trial included a broader range of tumors, including also patients with node-negative disease. For this reason, we wanted to perform our analysis, and we included individual patient-level data from a patient diagnosed with hormone receptor-positive, HER2-negative early breast cancer, enrolled in 3 adjuvant phase 3 randomized trial conducted between the MIG and study group. And the trials that we included are the MIG-1, GYM2, and GYM3 trials. Therefore, we categorize the patients in 2 different settings. The first setting are 2 different cohorts according to the inclusion criteria of both monarchE and NATALEE trial. So the high-risk cohort and the non-high-risk cohort. Afterward, we divided the patients into other 3 different categories, namely the concordant non-high-risk cohort, so patients at non-high risk for both the trials, concordant high-risk cohort, so patients at high risk of recurrence for both trials, and afterwards, the discordant high-risk cohort, so patients considered at high risk of recurrence for one trial, but not for the other one. Main objective in our analysis. The first one was to assess the prognosis in terms of disease-free survival and overall survival according to the inclusion criteria of the monarchE and NATALEE trials, while the other objective was to assess the prognosis, both in terms of disease-free survival and overall survival of patients included in the other 3 cohorts according to the concordance among the inclusion criteria of the 2 trials. Among the 3 trials, so the MIG-1, GYM2, and GYM3 trials, we included almost 7,000 patients, and after applying the main inclusion and exclusion criteria, we included in our analysis 4,795 patients. Looking at the first objectives, so the first result that we had among the 4,795 patients included, that has been divided into cohorts as follows. For the monarchE non-high-risk cohort, we had 72% of the patients, while for the monarchE high-risk cohort, the 28% of the patients. Looking at the NATALEE characteristics, patients that can be included in non-high-risk cohort for NATALEE trial were 33% of the patients, while for the NATALEE high-risk cohort were 56% of the patients. And if we look at the median follow-up of 7 years in terms of disease-free survival, we observed that the monarchE had 87% in the non-high-risk cohort and 69% in the high-risk cohort in terms of disease-free survival. While if we look at the results in terms of the population included in the NATALEE trial, they had 89% in the non-high-risk cohort and 76% in the high-risk cohort. So we had a delta of 18% between the 2 cohorts among the monarchE trial and of 13% in the 2 cohorts of the NATALEE trials. Looking at the results about the concordance analysis among the 2 trials, we had 3 different categories. So the first one are those patients with the concordant high-risk cohort, and there's been 28% of all the patients that we had in our analysis. Afterward, we had the concordant non-high-risk cohort, so patients that were not at high risk for both the trial, and there were 43%, so almost 50% of the patients. And finally, those patients classified as a discordant high-risk cohort. So 28% of the patients were considered at high risk for one trial, but not for the other one. And if we look at the results in terms of disease-free survival at 7 years in those patients with the concordant high-risk cohort, we have a 69% at 7-year disease-free survival, 84% in the discordant high-risk cohort, and 89% in concordant non-high-risk cohort. And looking at the results in the overall survival, we had 84% in the 7-year overall survival in the concordant high-risk cohort, 95% in discordant high-risk cohort, and 96% in concordant non-high-risk cohort, meaning that between those patients that can be included only in the NATALEE trial and those that are considered a non-high risk, we have a delta of 1% in 7-year overall survival, compared to a 12% of differences between those considered at the high risk cohort for both the two trials. So in conclusion, we can say that patients at high risk by the NATALEE experienced a better disease-free survival than those at high risk by monarchE trial, with a delta of 7% in 7 years disease-free survival. However, patients at high risk, according to NATALEE trial, but not included in the monarchE trial, have a slightly worse prognosis compared to patients considered as non-high risk for the monarchE trial. So delta of 5% in 7-year disease-free survival and only 1% in 7-year overall survival. We have to say that all these differences, even if of small magnitude, were statistically significant. And I think that these results may help physicians and patients to perform a better informed discussion on the need to escalate the adjuvant endocrine therapy based on the baseline risk of recurrence of the patients, particularly in those patients that can be included only according to the NATALEE trial results.